Good morning, everyone. I have 9:30, so we'll go ahead and get started. My name is Steph Weber, and I am one of our Hub team members this morning. I'm joined by the rest of our Hub with the Project Echo and Scope background. So if you have questions, feel free to private message us or private message Jesse Thomas. Today we have Andrea Whitwer with us. She's from The Ohio State University, but joining us today from a beach. We have Elsie Bush, occupational therapy. Michelle, John are not able to be with us today, but we have Kristen Kerwin, nurse navigator from Ohio University, and Stacy Lee as well from Ohio University. Sue's not able to join us today. Aaliyah Keeley from the Ohio State University's Nysonger Center. Troy, Amber are not able to join us today, but we have Kathy Wettig, who is up to bat for our presentation, as well as Pam Williams, who is joining us again today on our Hub, and Megan Stallhut and Giovanna Mayo, and Michelle is not able to join us either. So we have a smaller Hub team today. So we will likely not do breakouts and just stay together to learn from each other during the case discussion time. As a reminder, we've already gotten through 3 Buckeye Scope 2021 sessions. So today is the July 23rd, 2021 session on toxic neurodevelopment with Dr. Kathy Wettig. And I want to just make sure that we are welcoming anyone that has joined by phone. Jesse, are you seeing anybody that's a phone number?
No.
Okay, wonderful. So go ahead and take this time to rename yourself and put your name, agency, and info in the chat for your attendance. Also, as a reminder, we have captioning available if you scroll to the bottom and hover over the closed captioning. Next time on August 6th, we will have John Kinsel present on difficult conversations on through into October, which would be our last session, and that's going to be a great session. That is not TBD anymore. We do have some folks from the Ohio Policy Institute that are going to be joining us, so that's exciting. So for today, we're going to finish our introductions, have our core didactic with Dr. Wettig, do some clarifying questions, and then Sarah is going to present her challenge and opportunity, and then we'll just stay together and not do a breakout room. We'll just have a group discussion. And then have the wrap up near 11. I will take the time now to introduce Dr. Wettig. She is a graduate of the University of Cincinnati Medical School and completed her residency in pediatrics at Cincinnati Children's Hospital and did a fellowship in neonatology at University Hospitals in Cleveland. She was recently employed until her retirement in January at Good Sam Hospital and Cincinnati Children's Hospital. And she just did so much for the greater Cincinnati area to help these babies and families, and was the co-founder of the Neonatal Abstinence Syndrome Clinic at Cincinnati Children's, as well as co-founded the Collaborative for Children of Addicted Parents in our area here. So without further ado, I will let Dr. Wettig share your screen.
Well, good morning, everyone, and thank you for adjusting to the change from 2 weeks ago. I must admit, a sick puppy made me rush back from Florida, where I was going to do this presentation, but not from the beach. So I thank Dr. Williams Araya for stepping in for me. And I thank you for this opportunity to speak about how life has changed even before we see these children as they are exposed to opioids and other substances in utero. I have nothing financial to disclose. And now here is our baby as we first see them. Unfortunately, many of the babies come out withdrawing, and these are not addicted babies. We should not be speaking about addicted babies. These are babies who are withdrawing. And so we can speak about them having neonatal abstinence syndrome, NAS, or the new acceptable topic for opioid withdrawal syndrome, which is NOWS, as NAS can be from any substances the babies were exposed to. And I'm going to speak today on toxic neurodevelopment. TND is not an acceptable abbreviation, it's just mine. So neonatal abstinence syndrome, or NOWS, it has three hallmarks. The babies have central nervous system irritability. So you saw that baby, it was very, very upset. He was very tight, they tremor. And rarely, but it can happen that the babies who are withdrawing do have seizures. The babies definitely have gastrointestinal dysfunction. They have great difficulty with eating. They have diarrhea. And it's been shown that they do not tolerate many formulas well. And this is probably because of their ongoing exposure to opioids in utero and not setting up a good intestinal biome. They also have what we call autonomic disorders, which is the sweating, the sneezing that you see in the babies, and for which they are actually scored on the Finnegan score. But I want to say that as we define NAS throughout this talk, it is not just made by the need for pharmacologic treatment, but by these signs of neonatal withdrawal. And I'm happy to say that in Ohio, with early intervention, NAS does not require treatment in order to be a qualifying diagnosis. Does not require pharmacologic treatment. The babies, you probably hear that the babies had Finnegan scores. The Finnegan scoring started in 1976 with Loretta Finnegan, and it is a scoring based on symptoms of withdrawal. This does not speak to what the babies can do, but what symptoms they're showing. And these babies look very uncomfortable, and people are very willing to treat based on symptoms of withdrawal. But as I will show later, there are very much concerns of still treating babies with opioids even after we see them. So I am very happy that we are now looking at a different way to look at these babies, and we are using the eat, sleep, console method. And this is based on neonatal functioning. Can these babies eat? Can they sleep for a good period, at least an hour out of every 3? And can they be consoled within 10 minutes time? Because as you can imagine with the Finnegan scoring, there are many things that can cause a baby to be irritable, and it doesn't have to just be withdrawal. We treat opioid withdrawal, as I mentioned, with pharmacologic care at the ultimate. And those babies in the Cincinnati area are treated either with methadone or buprenorphine. The other treatment for neonatal withdrawal is morphine, and there will be a multi-center trial comparing these treatments amongst babies who require pharmacologic treatment. If the babies do not respond to first-line drugs, they are treated with either phenobarbital or clonidine, and these babies can be discharged on either phenobarbital or clonidine. But hopefully before we get to pharmacologic care, we have really maximized the non-pharmacologic care, and this is the swaddling of the babies, putting them in quiet, dark rooms, using high-calorie formula so that they do not have great weight loss. But let's get to what all this means actually long-term, and that is, if we look at the symptoms the babies show us, we can see that they are related to changes in neurotransmitters, changes in the brain, and these are changes that have gone on over development. And actually, over development, we must think that some of these babies have withdrawn many times before we see them, particularly in mothers who use heroin or other substances in which they withdraw. But even if moms are not on sufficient MAT and they're showing signs of withdrawal, their babies, their fetuses may be withdrawing. So as you look at this, you see at the time of withdrawal, what we have an increase in acetylcholine and an increase in noradrenaline. And you can see the symptoms that would come from having those increases. We also have a decrease in dopamine and a decrease in serotonin. So you can also see on this slide what symptoms the baby would have because of that. Now, how does this all work? Well, just to get started, these neurotransmitters are present as early as the first trimester. So we are seeing that they, from first trimester on, if we are changing how the baby's neurotransmitters are reacting, that we are also changing what they should be doing in a normal situation. And that is even within neuron genesis and neuron differentiation. So the noradrenaline, dopamine, serotonin, and acetylcholine are present in first trimester. GABA and glutamate, which are those transmitters that either excite or depress certain neurotransmission, are present in the second trimester. And so with overactivation and withdrawal, changes to the brain can occur. So here's the central part of withdrawal, or actually use of opioids, and that is the brain reward center. Now, we have a brain reward center so that we can live. Our brain reward center is set off by many things we do every day. Eating, sleeping, because we want to take a nap, having friends over, having intercourse, having sex, does set off our brain reward center. This is survival for us. But opioids can hijack this center also, as you can see, do other things. Opioids, the stimulants, even marijuana, can stimulate this center in order to change the outcome of the dopamine. And dopamine first is stimulated at the ventral tegmental nucleus, and it then stimulates the nucleus accumbens, which is our overall behavior center. And as you will see on this slide, whoops, went one too far. But on this slide, that these two areas, the ventral tegmental area and the nucleus accumbens, are very much related to the prefrontal cortex, which gives us our executive functioning, cognitive control. It's related to the amygdala, where our emotions are, to the hippocampus, where our memories are, and to the hypothalamus, where our stress and hormonal responses are. So any change to the neurotransmitters here, to the dopamine, to the GABA, to the glutamate, will affect the fetal brain. Now, I put here the insula because this is a very interesting part of the brain that I just really started paying more attention to. And it is kind of the major communication center for the brain of our sensory input, our emotional functions, motivation, our cognitive systems. And all of this is interrelated right here. And as we see, you see just all of the different things that we have in our life, our behavior, our decision-making, our emotions, our bodily feelings, whether they're, we call interoception, those feelings we get, oh, my belly hurts, or oh, this food's not going through well, or my something's causing my leg to hurt. Those type of things from inside us, or our salience detection, which is the way we interact things that are coming in from the outside of us. These are all related through the insula, which is related to those other areas that have been strongly affected by the changes in the dopamine, the serotonin, the acetylcholine, the norepinephrine, the GABA, the glutamate, all of those things that are affected by overstimulation of our reward center by the opioids. Now, this was a very interesting study in which this is normal, well, I should say unexposed children. And there was no reason to think that they were at risk for other than normal development. And you say, oh my gosh, this looks like just a lot of pictures. But what I want to point out, this area here, the SA area to the far right, excuse me, to the far right, this is the salience area, and that is the area that coordinates those things that are coming in from our outside. And what I want to point out there is that it is highly active even in the neonatal period and becomes more so over the first 2 years of life. That which is just to the left of it is the default mode. That's the interoception. That's where we feel from inside. And that too is highly active in the neonate. What I'm trying to say by this is that we are very aware, at least, of what's going on inside our bodies and what's going on outside of us, even in the neonatal period. And what was shown here was they looked at these children at 2 years of age, did studies, cognitive studies, and showed that changes in these type of MRIs were related to the cognitive outcomes. Again, these were unexposed children, but it's just concerning to know how much of the brain is already allowing us to know what's going on outside of us and how all of this can be affected from inside. So these studies, this MRI, this is from Stephanie Merhar's earlier paper on MRIs done after in utero opioid exposure and done in the neonatal period. And this is to show that in 20 babies that were exposed, she actually showed in 13 of those babies changes in the MRIs compared to the 20 babies who weren't exposed. Now, this paper did not suggest what this meant, but it is just concerning. And if I go back one slide, you'll see that our salience is up here, our default mode is back here, and where she's showing changes, here's our salience areas, here's our default mode areas. So it's just concerning to say we are set up even before anybody sees us. So what is toxic neurodevelopment? It is affected by in utero drug exposure. I must say it also has to be affected by the environment the mom's in, how much stress she's having, genetics. What does a mom, why did the mom even get into a pattern of substance use? We also, as we're looking at the symptoms, some of these babies with prematurity and intrauterine growth retardation or cigarette exposure can show all of those hyperirritability symptoms even early on. Outcomes can be affected by the parents' education, their socioeconomic status, their own mental health, the family genetics. So I'm not going to try to say that anything is a clear picture. Give this drug, this is what we're going to have as an outcome. I'm just going to say that these babies are at great risk. And in the studies that I will show you, they at least, and actually in many of the studies, moms were on methadone for the majority of their pregnancy, which again is somewhat concerning because the treatment we're giving moms is affecting the babies. So these are some of the abnormalities we're going to talk about. Affected visual center of the brain and retina, deficient working memory, poor inhibition, abnormal sense of body and space, abnormal attention and learning. And when I talk about abnormal, that's kind of a non-distinguished word, but what I mean is that it's different from those children who were not exposed. And as you talk to people who are seeing these children, they'll tell you that it's different from other children who seem to have the same problem, that their abnormal sense of body and space is not quite like the preterm who has some sensory issues. And their abnormal attention is not like a kid with ADHD, but for other reasons. We'll see effects on fear and anxiety from the amygdala, abnormal attachment. And this is not necessarily just because a lot of these kids are in foster homes. I mean, this can even be some children from early on, if they're adopted even early on. Abnormal muscle tone and movement, and the abnormal gastrointestinal system, not tolerating the formulas, not tolerating some feedings. So these are things we do see in the children. Now, these medical issues, this is a paper that was published by Dr. McAllister and Wexelblatt, who are still at Children's, and Dr. Hall, who moved from Children's. These are children born in 2014 and 15. They were at least 3 to 4 years old by the time their charts were abstracted. So this is just looking at which of these problems were seen in children that were opioid exposed, had actual treatment for neonatal abstinence syndrome, or were not exposed. Remember, this is to a referral hospital, so this is more likely to be seen. But you can see that if a baby was treated for neonatal abstinence syndrome, there was a higher problem with torticollis, plagiocephaly, strabismus, otitis media, and hepatitis C exposure, and that even those who were opioid exposed had an increased incidence of strabismus compared to the general population. This to just remind you what torticollis is, the tightening of the muscle on this baby on his left side that causes him to tilt his head. This then leads to flattening on the other side of the head. So this is really puts babies off balance, but it also changes their visual field. So this is something that needs to be diagnosed and treated quickly because remember, again, this baby is developing his overall perspective on the world, and we want it to be straight, not crooked. These are just some eye concerns. This one speaks to strabismus, which is the eye either going in or going out. But pertinent to our case that will come up, these babies can also have other eye problems. They can have astigmatisms. They can have jumpy eyes. So this is clearly seen. But in papers looking at eye problems, there are many more eye problems. About 10% of the children who have been exposed will have eye issues. So this Boston paper was actually with children of lower socioeconomic status. And so I want to point that out because even with this, you will see that the children showed more problems than their non-exposed peers. So this was, as you can see, over 8,000 non-exposed children, and of that, 3,000 were included in the analysis. And then we had 454 exposed, 281 who had actually treated for neonatal abstinence syndrome. Those who were exposed to either heroin, oxycodone, or methadone. There was an increased incidence of low birth weight and prematurity in those who were exposed. And I will move on. They also had issues with attention deficit, conduct disorder, abnormal physiologic development in the years 0 to 6. Now that compares to also what we saw at Children's Hospital with the children who were opioid exposed and had neonatal abstinence syndrome, much higher incidence of delay in development, behavior disorder, sensory disorder, and speech disorder, even in those who were opioid exposed. This study looked at behavioral outcomes even at 5 to 8 months, and these mothers were in treatment. So they were treated with either methadone or buprenorphine. The mothers in treatment were excluded if they used cocaine or amphetamines, but they could have had a low alcohol intake, which I'm sure we heard 2 weeks ago that even a low alcohol intake can cause issues. And they did smoke cigarettes or marijuana. The control mothers did not use any illegal drugs, alcohol, cigarettes, or marijuana, and they were not treated with methadone. So at 5 to 8 months in testing, there was no difference in cognitive functioning. But the exposed infants showed a decrease in self-regulation and an increase in sensory-seeking behavior. And then also with the parents, if the babies were quickly treated for NAS, that caused higher parental stress. The parents had less control over their baby's symptoms. And the longer the hospital stay, the greater parent-child interaction dysfunction. When we looked at mother-child interaction at age 4, this is a different group. Again, the mothers were treated with methadone or buprenorphine. There was an incidence of alcohol and cigarettes in the exposed mothers and not in the control mothers. But in looking at this, the group influences, so whether or not the babies were exposed or not exposed, showed that the exposed infants had decreased behavioral inhibition, they had poor sensory motor functioning, and short-term memory problems compared to the unexposed. When they looked at the mother-child interaction, this is to take out the social factors, they did show that the exposed infants had decrease in narrative memory and vocabulary skills, possibly related to maternal education and socioeconomic status. So this one was a very interesting study I like to include because we will always wonder how do these kids get in trouble in preschool? And this study looked at a child at 4 to 5, their ability to use eye movements to predict another person's actions. So if you can't figure out what somebody's doing by watching them, you might not understand when the teacher's kind of saying, come on, let's go, we're going outside now, we're going to put this puzzle away, or whatever. But also, you don't learn to imitate and learn from others based on your inability to use eye movements. And how they did this was quite interesting. In the top part of this slide, the woman has her hand on the ball, and the children can watch her and look at watch where the ball goes. On the lower slide, it's a machine. So they have no interaction with the person, and it's the machine they have to figure out when that's going to go and watch the ball. So you can see here, if it was the machine, then the children who weren't exposed still could do it better than those who were exposed, but they were still taking much more time with the machine. But once it was a person, they were able to do it much more quickly. But those who had been exposed were not a whole lot better than they were with the machine. They were not able to read body movements to predict their own eye movements here. And I think that's an interesting study to have us say, well, maybe these children really, it's not that they're just not paying attention. They just really can't even interpret what's going on if they're paying attention. So I went through this, the Boston cohort, again, even showed problems with the children after 6 years of age. And the one thing we talked about, they showed this even earlier, but ADHD is not ADHD in these kids. It's not the ADHD that gets treated with Adderall or Ritalin or whatever drug is in favor right now. It's a different type. And in fact, some of these children, if you treat them with amphetamines, such as Adderall, will get even worse. Conduct disorder, emotional disorder. I'm not a psychiatrist, I'm not a psychologist, but those seem like kind of basket terms for kids who have, are not working in the same vein that other children. And again, it's probably a different type of reaction to their environment that brings this diagnosis on. This one, mental health after in utero exposure. These were 10 to 12-year-olds. And I think that what is interesting about this slide is if you compare drug exposure and alcohol exposure, and these were separate. These kids who were drug exposed were not alcohol exposed and vice versa. You can see that the drug exposed kids look much closer to the alcohol exposed kids than to the reference population. So I think that as we're looking at these groups of children, we need to have a separate area where we just take care of kids who were exposed in utero and try to figure out what their issues are. This one, it goes back to the outcomes in ADHD, but what is to be shown here is that even those children adopted into a high socioeconomic status had the same degree of ADHD. These are the babies who were exposed and then adopted, had the same degree of ADHD as the controls in the lower socioeconomic. So this is to say, this is not just related to your environment, but related to your in utero exposure. And unfortunately, this study out of Australia shows that there was a progressive decrease in ability to keep up with their peers. These are looking at standardized tests that are done throughout Australia at 3rd, 5th, and 7th grade. And you can see that those children who had neonatal absence syndrome fell off further and further from the other. This is New South Wales, the state in Australia, and you can see how they fell off from those who were their match controls that were not exposed. So this is, again, a concern. Now, this is not to say that there was anything done, any therapies done to help these kids catch up. So I'm going to end with what are the age-based concerns and what resources we know that we have within our Cincinnati area. I will encourage anybody to please just chime in with other resources that that either we need to establish or we need to find. We are working hard in this area to coordinate as many services as we can so that we can allow parents, foster parents, kinship parents to access the resources. But in our area, the birth concerns, neonatal absence syndrome, we are trying to identify by toxic screen and maternal history any exposure so we can predict which babies might develop neonatal absence syndrome, which babies might be severe enough to need treatment.
I think you're muted.
We have a follow-up clinic for exposed and treated infants. We have nutritional support. The hepatitis C babies, exposed babies are followed to refer, if their test is still positive at 18 months, to refer to GI. At 0 to 6, we follow their muscle tone. We look certainly closely for torticollis, plagiocephaly, sensory issues, digestive issues, and you can see what services we try to access. 6 to 12 months, and these are times at which we are seeing these babies within our clinics, and you can see what we address there. Sleep problems, eye problems, and hearing problems become even more obvious at that time, and we try to refer for occupational therapy. We try also parent-child therapy so that the mothers can understand why their children are are this way and not just becoming frustrated by them. We have a good connection with ophthalmology, and many of these children, regardless of the household they go into, even without smoking in the household, many of them can have repetitive ear infections and hearing problems, and they need to be screened for that. Again, this has been in the literature. There's a few articles about the ear and opioid exposure. 12 to 24 months, we're starting to see the speech language delay, their behaviors, throwing, biting, head banging. Some of these are sensory issues. Some of these are, I can't tell you what I need. And then sleep issues. 24 to 36 months, terrible twos on steroids. They are not able to play with toys. They're always moving. They have poor attention, poor sleep, poor language. I put there again, parent-child interactive therapy, because families need to be able to understand too why the children are doing this. At 3 to 5, where our concerns, as you see, oppositional, defiant. Well, they're probably not wanting to be defiant and oppositional. They just don't know how to be what they're supposed to be. Speech delay, poor attention, poor fine motor. We want to, at this age, we want to be sure that they have been evaluated for an IEP. And that is also to talk to the parents. Don't just ask for an IEP, ask for an evaluation to get an IEP. And then we have here, and in Butler and Warren counties, the Therapeutic Interagency Preschool Program, which works with many of these children. So the other point I want to make here is that if we are going to work with the child, we need to work with the parents, and we need to, as much as possible, work with the birth parents. So these are things that I would suggest. Support parental sobriety, decrease the stigma of in utero opioid exposure, because many of these moms don't want to bring their kids in and say, oh, it must be because I use drugs. We want to encourage their confidence in their child's physician and specialty medical services. We want to encourage their confidence in children's protective services. We don't want them to feel like every time they, quote, do something wrong, CPS is going to be there to take their baby away. Childcare needs to be educated, and I know we're working very hard to do that. School systems need to be able to identify and meet the needs of the children, and drug prevention programs need to work with the entire family. And from here, thank you all for what you do. On the PowerPoint, there are the references of things that I have spoken to. So with that, I will stop sharing my screen and take any questions anybody would like.
Thank you so much, Dr. Wettig. For those of us who have been on this session with you a few times, we appreciate you adding in some new material as well at the beginning. And I wanted to just call out, Betsy put a question in the chat earlier on about, the question is this true of all exposure or just opiates? But Betsy, could you come off mute and maybe share a bit more about what specifically you were referencing?
Sure. We were on the slide of abnormalities of neurotransmitters. And so I was just wondering if those issues are across the board with different exposures or just the opiates.
Well, that slide, of course, was related to opiates because those 4 neurotransmitters are very much affected by opiates. But the dopamine is very much increased with the use of amphetamines and cocaine. That they both work to increase the dopamine in the space between synapses. So, but we don't see the same type of withdrawal symptoms, or we don't recognize them to that extent. But when you look throughout gestation, there are difficulties with increased dopamine and dopamine receptors. And in fact, one of my psychiatrist friends would tell me that amphetamine exposure in utero He can tell even in the cry of the kids when they're 4 and 5 years of age, because there's quite a difference there. So that slide was only particular opioids, but many of those, even as that first slide we showed with the reward center, that's why babies, you know, who have been exposed to nicotine, they're very crabby babies too. And you can see, I mean, you could take a baby who had been exposed to nicotine, and if you didn't have a drug screen, or you didn't believe mom's drug history, you might give them a Finnegan score that was worthy of treatment. So does that answer your question?
Yes, thank you.
Mm-hmm.
Other questions from anyone on the line? Feel free to unmute.
Oh, I see a question here from Sarah, who's wondering, is there any type of manual or journal article that talks about NAS, common symptoms issues, recommended interventions, programs, or evaluations, and other supports or recommendations for both baby and caregivers?
I don't think there's an article that does all of that. I'm waiting for Stephanie to write that article.
Andrea and I will write that book along with our hub team here.
Right.
But I agree with you, Sarah. I think that, yeah, that would definitely be an entire textbook, and it's definitely needed. There's not enough information out there, and parents are so hungry for it all. But we will make sure to remind everybody we do a quarterly newsletter, and that in that quarterly newsletter we share some of the main research articles related to NAS and symptomology, treatment, things of that nature. So make sure you get on our mailing list for that, and we can add more of those in future newsletters as well. But always email us if you have certain questions, because there are some that are literally being, some articles that are literally coming out as we speak. So great question.
So, and I think many of those things are changing as we get to know these kids more and more. I think, and that's the ongoing thing too with this whole session, and what we're trying to do through the University of Cincinnati Center for Excellence in Developmental Disabilities. You said we're trying. I mean, we are working in this area, but we encourage anybody to let us know what you found works or what you're seeing in your areas, because we all have to come together with the knowledge. We're the ones that have the knowledge of these kids, and if we don't express that, the schools, everybody else are going to just think these are bad kids.
I have a question. Given the concerns in the research for eye problems and ear hearing problems, are there, other than increased vigilance, are there specific recommendations for referral to audiology or ophthalmology at certain ages, or only if symptoms are seen on, vigilant physical exam at baby checks?
I think that it all depends on what the quote vigilant physical exam means. I would recommend what we do at 6 to 12 months, which is an eye screen with the eye screener to look for any suggested issues. We routinely do a repeat hearing screen at a year of age. So, I mean, I think it's more than just what you're seeing on exam, but do a few at a screening test at particular periods of time.
I have a question too. I have a group, pregnant women that have opiate addiction, and a lot of them are also on drug medication for their anxiety, depression, PTSD. And like, how do we like add all of that into there too? Because, and then I've got a couple bipolars which have Lamictal, and so there's so many things that they're actually affecting the baby.
And that has been a difficulty. I've seen a mother who was on Lamictal, and that baby had very serious withdrawal type symptoms. And I think we need to even be educating our neonatology colleagues about what type of, how these drugs work, to really speak to what symptoms the babies are having for one or the other. That's why I'm hopeful that we start adopting Eat, Sleep, and Console, because some of those symptoms don't affect the babies functionally as badly, but they still give them the tremors and the irritability, etc. But it's, I mean, I think we have to educate to, look, it's not just the methadone, it's not just the heroin, it's not just, you know, the opioids. We can see these symptoms, and the best we can do is to at least stop the continued exposure to drugs after birth.
Stacy, I have a couple of questions. The first one is what are the effects neonatally on baby when mother has been using really high doses of gabapentin, both prescribed and with an adjunct like their own street gabapentin?
Right. The babies do show signs that are like withdrawal. Some babies have actually been treated with gabapentin to help this, but it needs, again, to be pointed out very closely to the people who are treating them, because the babies don't necessarily just respond to methadone or buprenorphine then. But it is, I have had babies that have been very symptomatic because of mom's gabapentin.
Okay. And my second question is, I thought it was really interesting that what you mentioned about the failure to use eye movement to predict another person's actions. And we see that from the stance of the mother as well, who was exposed herself. But what type of provider would be an appropriate referral for a toddler, for example, who's exhibiting those symptoms?
I'm gonna let
that characteristic.
I'm gonna let Stephanie help me with this one. Stephanie, I'm not sure exactly. There are, you know, probably opticians to speak to this, but or optometrist or whatever, but I don't know.
Yeah, I've seen this in a number of children that I've worked with, and it's very similar to children with other types of kind of anxiety disorders, where they just misinterpret their environment. And so it's a lot of approaching these kids from that developmental perspective, just like we would do with other developmental concerns. So writing social stories to help them understand what's to come in their environment versus just relying on their reactions in the moment. That I have found to be incredibly helpful when we can slow their bodies down and have them, at least over time, learn how the child didn't take their toy on purpose to hurt their feelings or to make them mad. It was just they wanted the toy too. So it's certain things like that where just the information is overloaded in the moment. And a lot of that is what we see in preschool and why they end up getting expelled from preschool so frequently, because they're misinterpreting information all day long, and there's so much sensory stimulation and overwhelm to their system that a lot of it is also coaching the folks in their environment to model for them how to slow down and do redos. A lot of it is like, okay, they didn't, you know, this is what you can do instead in the moment. So let's take a deep breath. And I think this works a lot with adults. I mean, I don't know, maybe I'm just being biased, but I have to do a lot of redos with my husband as well. So, and I was not prenatally exposed. But I think that, yes, preparing kids and doing a lot of in the moment coaching and redos and just allowing children to not feel shame for having that reaction, but giving them a sense of you can overcome this and you can do this with more respect. We talk a lot about it. You know, let's redo that with respect. Let's redo that with flexibility. And even though respect and flexibility may be real tough for a 3-year-old to understand, we want them to practice over time knowing what that means. So I don't know, Andrea, Aaliyah, other Hub team members to chime in.
I was just going to share that I think a Help Me Grow early intervention team would be a perfect set of professionals that could help with that. There's the developmental specialist on the team that could really help with some of the cognitive, social, emotional things. The occupational therapist can also help as well. So I think connecting a family to early intervention would be a great resource for this particular intervention need.
Yeah, I agree with Aaliyah thinking, and I think you're right, Steph, a lot of it is around that skill building and teaching them in the moment what to do, but also just building those skills and those positive social emotional pieces during other pieces and practicing all of those different aspects that they need to do in the more chaotic and sensory filled environment. And yeah, so a Help Me Grow team that can kind of take it from multiple angles would be a great kind of first step.
Thank you.
Thank you guys for these wonderful questions. Again, if you have any challenges or opportunities, we'd love for you to share those. So email Jessie, and don't forget your evaluations. Please, 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 we take those into consideration. We meet weekly so that we can respond to your needs. So please let us know how this worked for you, staying in the big group, since that was a difference than normal. So yes, and Lisa, echo that. This mom is really lucky to have you, Sarah. So thank you for the work you're doing in Wood County. Have a great weekend, everyone.